Good evening, friends. Hope you all can hear me well. So our today's topic is musculoskeletal key to knee pain. We are all stuck to an idea that knee pain is around the knee, or we are stuck to a concept that the knee pain is always related to muscles. And there are many more such small concepts, which I would say, means we think the knee pain is from the local structures, but we never go beyond it. And that is what is affecting all of us. So what we are trying to tell you today is an idea of understanding the knee pain is no more limited to local. It can be from the global. Today, we are just going to talk about the perspective to knee pain, not about the techniques and rehabilitation methods. I want you to open up your perspective to understand the knee pain, which you all commonly miss into your day-to-day practice. I hope I'm very well audible to all of you, and this session will be help you to understand all of these. Now, if you have any queries, please place it in the chat box, and please mute yourself so that all the people can hear clear everything about it. I can't go and mute each one of you. Okay, so please mute yourself. It will be very pleasurable that we can hear each other very well then. So knee pain. Classical way to see knee pain is with brands. We Indians love brands, so we always see knee pain with brands. Osteoarthritis, chondromalacia, IT band syndrome, pes anseris bursitis, patellar tendinitis. We always know our diseases and conditions with brand, and we don't know them because of quadriceps inhibition, we can say popliteus overfiring, adductor dysfunction. We don't know them with these names. We just know them with the big brand names, which makes no sense for rehab. And osteoarthritis of one guy will not be same as osteoarthritis of another guy. There can be hundreds of different reasons for being the same and not same. So today we're going to see the non-classical way of seeing the knee pain. And I'm not going to talk about any of these brands and how to manage them. The new way to see knee pain is a kinetic chain approach. How one joint affects another joint and how another joint affects the series of joints. So today we're going to see how these series affects each other. And that is more important to understand about the knee pain instead of just looking around the knee. So today we're going to see how the kinetic chain approaches to knee pain, how they are so interlinked, and why you should not always look local. I'm not saying everything is not local, but everything is not global and everything is not local. So my approach to see any pain includes combining of manual therapies, dry needling, cupping kinetics, nutrition, emotions, and corrective exercise. These are my approaches to rehabilitation and my approach of seeing a client. So practitioner and student should learn different phases of pain and how effective they are to assess them. in managing with dry needling, cupping, exercise, and nutrition. We'll try to get your approach to understand the theory, rationale, and approach to its understanding. Hands-on application and evaluation methods makes your approach much easier to understand. So what are the structures involved in knee pain? Muscle, tendon, ligament, bursa, and the nutrition. These are normally structures that are involved in knee pain. The muscle can be local, which is around the knee, or the muscle can be global from anywhere in the body. Muscle like processus can also result in knee pain. Ligament like lateral or like ligament of, like, let's say a deltoid ligament can cause knee pain. Local bursa can cause knee pain, or a simple nutrient deficiency can result in knee pain. And knee pain can go beyond this, which is not limited to structure, but beyond. It can be a lymph, it can be an emotion, and it can be a central dysfunction. So we are trying to understand what are the structures involved in knee pain other than this. A rehabilitation or a joint pain is a complex scenario in pain management. So all the mechanical and chemical structures can go from the around what we call as from prostaglandin, histamine, 5-hydroxytryptophan, bradykinin, cytokinin, go towards the spinal cord and create pain. This pain will come back from the brain and tell you to reflex inhibition of the muscle, that is reflex muscle spasm. To negate that, you have to do a solution to it. And that solution is not limited to trigger point therapy or chiropractic adjustments or resistance techniques. It can be anything of these. So don't limit yourself with limited techniques. You can use anything that is ethical, most probably, and that should resolve your pain. So pain, I would say, is either structural or functional. Structure is focuses on pathology or static structure, emphasizes diagnosis based on localized evaluation and special tests. These are my, I would say, day-to-day approaches if I see only 20% of the client, which are directly affected with structural evaluation and the static diagnosis is true in them. Since we are dynamic, we are live, and we keep moving into our day-to-day life, functional diagnosis makes more sense. Recognize the function of all process and system within the body, rather than focusing on a single site of pathology. So both structural and functional assessment are true and right, depending from client to client. But structural evaluation and treatment is limited to correction rather than looking around the functional assessment. So body system is not limited to muscular evaluation. Body system is not limited to muscular or articular evaluation. It goes beyond muscular. It goes to a nervous system. It goes to articular. It goes to lymphatic system. It goes to emotional based system. And all these results in optimal structural alignment, which results in optimal neuromuscular control, which in turn gives you optimal movement. So if I say a knee extension is not limited to muscular or articular system. A knee extension also involved nervous system. Yesterday I had a client, I'm not going to go too far, who had a knee pain, a bilateral knee pain. And we have worked all around her knee. We have worked on the pelvis complex. We have worked on her ankle complex. And we have spent somewhere around, I would say, 6 days on her already. And she feels good out of pain when she is in the clinic. But as soon as she goes home, the pain comes back. The pain comes back. So that tells us that we are missing something in our system, and that is not right, which is solving the problem. Hence, we again looked into evaluation and we have found she just needs a right music frequency. She needs a frequency to listen. And that frequency is to normalize the nervous system. And we gave her that. And that frequency normalized the nervous system in her body. And we asked her, how is the pain? She said, it's much lesser than every other session I've taken from you. And it's been 2 days last, and still she doesn't complain of pain. So it tells us a lot about that we have to go beyond healing the pain. We have to also look at the nervous system. We also have to see the right techniques to do it. So regional interdependence, seemingly unrelated impairment in a remote anatomical region may contribute to or associated with the patient's primary complaint. Regional interdependence, we are trying to say, it's not limited to local. It is not limited to local. We are trying to say you it's not limited to local. It's beyond local. It can go anywhere, back to hip joint, spinal structures, shoulder joint, ankle joint, depending from client to client. Optimal alignment. Alignment of musculoskeletal system, allowing posture to be balanced with center of gravity. Ability of neuromuscular system to perform functional tasks with least amount of energy and stress on the kinetic chain. People with flat foot usually compromise this at the neuromuscular system because they have to spend more amount of energy to do a same task. If I say a client with a flat foot, he would have low arches. To do the same step or a movement, his body would stand more energy because his ankle cannot do shock absorption, which may end up at knee if the muscles are weak and result in knee pain, or can go higher depending on which muscle is weak and causing pain. So optimal muscle length tension relationship at which our muscles are capable of developing maximum strength. So rehabilitation is again not limited to musculoskeletal muscles, but also to the structural alignment. Kinetic chain approach. Our approach is to see a proprioceptive. Are proprioceptive inputs better from the ankle? If yes, the knee functions will also be better. If not, the knee has to overwork to stabilize the ankle. Hence, it can get fatigued earlier and result in pain. Length tension relationship, the optimal length at which the muscle can produce the greatest force. If the length tension relationship is not proper, then agonist and antagonist relationship would get affected. Force couple relationship, the synergist muscle of the muscle to produce the movement around the joint. The same group of muscle which assist the joint, they need a force couple for transmission of force. And if they are tired, this force transmission would not take place. That can also result in knee pain. A knee pain, a best example I would say for the force couple can be psoas to quadriceps. So if the quadriceps are weak, psoas overfires, and psoas would compensate for quadriceps. And the more you walk, the client can come with the back pain because the psoas is getting more fatigue and causing pain because that's the functional muscle. But quadriceps cannot function, for which a psoas will function and result in pain. So that's a force couple relationship. Arthrokinematic is basically the ability of the joint to move through its biomechanical range of motion, which is limited, hence resulting in pain. So kinetic chain dysfunctioning like excessive pronation can result in metatarsalgia, bunion, plantar fasciitis, neuroma, and excessive tibial tension in tibial posterior and peroneus resulting in shin splint, and put a lot of stress on the knee, causing tendinitis, injury susceptibilities. So I would say your knee pain or tendinitis or knee injuries are more because of the flat foot. If I don't release the ankle properly, knee outcome would be limited and not long lasting. So the whole idea is that kinetic chain is not limited to muscular chain, it is also limited to arthrokinematic chain. And the more you work on proper alignment, the better results can be seen in the clients in long-term basis. So I always tell my clients the knee is like a matchstick, which is between two fingers. If you're going to have a lot of pressure from the top and bottom on the matchstick, the matchstick will bend. And that bend is the knee pain. And that bend is the knee pain, which is having a lot of pressure from the ankle and the pelvis. And that is what is resulting in knee pain. So what I want you to see, the knee pain is again not limited to local. It can be local, it can be global. And you have to balance these muscles to minimize the pressure on the knee, and the knee pain is gone. And that is what we call as osteoarthritis. Just a dysfunction between a glutes and a quadricep is a major reason for riding of joint and knee osteoarthritis. If you balance them well from the pelvis, from the ankle, and maybe from the TMJ, then the knee pain could be reduced to so extent that ADL activities can be achieved pain-free if required. So basically, we are trying to balance the agonist, the antagonist, the synergist, the stabilizer, and the neutralizer. We are not working just to balance the agonist or just to balance the antagonist. We are not working just to balance the synergist and stabilizer. We have to create a balance between all these structures, that is agonist, antagonist, synergist, stabilizer, and neutralizer. The better you work on it, the better results can be noted. If we just work on one structure, all the results that we get are temporarily. Then we can say the osteoarthritis will never go. You have to live with it or get a TKR done. But if you do a good balance, then you might not have to do that. So the whole idea is to see the body from the front, compare the left with right, and see to get a line as much as possible. Have your client stand in these postures and try to compare between the left and the right structures. See if you find an imbalance. See if you can see any anomalies in them. And the more you note from the bottom to the top, the better results you could note to them. Dynamic function. Try to relate to the basic functions: squatting, pushing, pulling, and balancing. See how those structures react in these activities. Are they compromising at one point? Are they doing well in the structures? Are they playing interplay, joint play are all proper? Is physiology and biomechanics proper in the play of their doing the activity? If yes, then the knee pain is not to be worried about. If no, then you have to make sure these structures are aligned so that knee pain is much less. So if I see these two structures, which a guy is walking on the right of my hand and girl on the left, right udder, I could see the knee caving in, and that is can be seen because of tight adductors. And he has to place his, every time he does a step, he has to do a wider angle. So what I could see in him is I might have to work on better ankle and pelvis to get the knee pain off. Similarly, if I look at the girl, I might have to work on the pelvis to get a better outlook of it. So it's not always about the knee, it's all about the structures around it. So in male, I have to work on pelvis and ankle, and female around the pelvis to get the knee pain off. That is what I said, dynamic. Now let's see how many structures are involved in knee pain. And if you can see them well, you can understand them well. So if you can see this structure, which is on the gluteus minimus, so on the right hand side top corner of the screen, this structure is the one which can result in lateral knee pain. It's not compulsory that it will cause radiating pain from the thigh to the ankle. It may only result in knee pain on the lateral aspect. If I see gluteus medius and medius, which is on the post, giving you pain on the posterior knee, whereas minimus on the lateral side of the thigh. Whereas quadricep is giving you on the top of the knee, and also the adductor magnus is giving you on the top of the knee. So there is no one muscle that can result in the knee pain on the top of the knee. It can be multiple. So the quadricep pain can be also on the top of the knee because of procerus. Quadricep pain can be on the top of the knee because of the psoas. Adductor magnus can result in knee pain. Adductor magnus can be tight because of inhibited rectus. Gluteus medius can be pain because of the tight QL. And gluteus minimus is inhibited because of the gluteus medius. So all these structures are so interrelated and they all result in knee pain. And most of these structures, if I see gluteus medius and minimus, they are not around the knee. Still their pain referral pattern is around the knee. The adductor magnus is long and it has two referral patterns. One is on the top of the thigh and one is on the around the knee structures. So not every structure can result in knee pain. You have to look around. What all muscles can refer the pain? Is the muscle local of the around the knee, or is it coming from the pelvis, or it can again come from the ankle also? Ligaments. Here we have not got the local ligaments because we all know local ligaments can result in local pain. Here we want to see the global ligament can cause pain. So if I see hip pelvic attachments can cause pain around the knee here. And this itself can result in local pain. And which all these pains which you could see are the ligament referral pain pattern. And they are the ligaments of pelvis. They are the ligaments of pelvis. Mostly sacroiliac ligaments. And sacrococcygeal, sacrospinous, and they all result in pain around the knee. So the pain is not limited to muscle, pain is not limited to local ligaments. Pain can also be because of the global ligaments which are around the pelvis, around the ankle, and around the knee, which can cause pain around the knee joint. Bursa pain. Everybody says to work on the bursa. I don't like working on bursa definitely because bursas are paining because the bursas are getting compressed. Bursas are getting compressed because the force couple reaction between the muscles or the limb tension reaction between the muscles is not proper. So it's better to work on agonist and antagonist, balance the synergist to minimize the pressure on the bursa, and that itself should reduce the pain. Just working on bursa should not resolve the pain in most of the scenarios. I have worked on chronic bursitis, prepatellar bursitis pain by just activating the glutes, by just working on the psoas, and we have not worked even around the knee joint. So it's the bursa pain is a new approach that we see. It's not directly working on the bursa or around the bursa, but it is to get the pressure, the limb tension and relationship around the muscles in correlation to bursa. We would like to reduce that to maximize the response. Biomechanical causes. With the right picture, you could see the shoulder movement is limited, affecting the knee. And if you have a limited shoulder movement, that can cause knee pain. Ligaments in the elbow joint opposite side can also cause pain on the opposite knee. So knee pain is not limited to around knee. It can be opposite shoulder, opposite ankle. It can be opposite hip or same side hip too. But most of the scenarios we see the shoulder, and especially what we commonly I see is an opposite shoulder. Why? So that we have a habit of carrying handbags or something between our arms that will limit our shoulder movement. Any bag on the shoulder limits the shoulder movement, limits the shoulder swing. That itself limits the gluteal swing. That reduces the knee reaction time to ground clearance, which in turn can result in knee pain, where your knee has to work in a very short time now because the ground reaction force time is reduced. And that can cause pain too. So anything that like shoulder purse or anything that you're keeping on the shoulder is not only you're affecting the shoulder joint, but you're also affecting the knee joint. Some people have a habit of keeping something between the arms and walk, between the armpits. They lock it up and walk. That tightens the coracobrachialis. Coracobrachialis in turn tightens the adductors of opposite side to create the limited stability movement. And that itself, adductor tightness, can cause a knee pain. Even though you have worked around the adductors or knee when the client comes, but since you have not worked on the coracobrachialis, that perchal habit is not reducing, and that can also result in a knee pain. Pelvis and knee relation. As we know, the client having a weak pelvis, a client having a weak gluteus medius, will not be able to pull the knee outside, and that is going to put the knee more inside and result in knee pain. Most of the females that we know cannot have gluteus medius weakness, and if you see them, they have early stages osteoarthritis. If you just work on strengthening gluteus medius and release the adductors well, the knee pain would be gone. People with pelvic tilt, okay, so your abdomens are weak, gluteus will get tight, hamstrings will get short, and that limited hamstring movement will affect the quadricep movement, and that can itself result in knee pain. So knee pain is not limited to lateral balance, that is from the gluteus. It is also limited to anterior-posterior balance, that is from abdomen to the erectors. So if abdominal muscles are weak, the erectors would overfire. That will create an anterior pelvic tilt, limiting the hip pelvis movement, affecting the mobility of the knee joint, and cause knee pain. Not only knee pain is limited to what we call as pelvis, but is directly and equally affected with ankle. That is, if the proper ankle alignment is not there, if your knee is going medially because of the flat foot, that can cause pain. You can have tibial inward rotation and tibial outward rotation for the same pain and cause the pain in the knee joint. So tibial can have an inward rotation or an outward rotation, and that can put an additional load on the knee joint and cause you knee pain. People can have a bow leg or a knock knee. That can result in knee pain. So it's not always the local. These structures are global. And as I said, it's like a matchstick. You're getting a lot of pressure from pelvis, you're getting a lot of pressure from the ankle, and your knee decides where to go. It can go out, it can go in, and wherever it goes out or in and not aligned, that is what's going to cause you pain. And that is what we're trying to tell you in the structures, that always knee pain is not from the local. It can be from global, it can be from pelvis, it can be from ankle, it can be beyond that. We have seen knee pain because of opposite ankle ligament, ligament injuries. So client also came to us with opposite elbow ligament injury. So if a client came to with the right knee pain, he has a left elbow ligament injury pain. And we asked, do you have a history of left ligament injury pain? Left elbow ligament injury pain? He says yes. And as soon as we worked on it, the pain in the knee is gone. So again, the knee pain is not limited to the biomechanical faults in the knee or the shoulder. It is the ligament which creates stability and mobility of the joint. If they overstabilize because of the injury, that would limit the mobility of the muscles, and that itself can cause pain. The most important nutrition commonly we see that is weak in the client, that is CQ10. As soon as you place the bottle of CQ10 on the patient's body, the pain would reduce. And if that is so, the client needs CQ10 rather than a physiotherapy. So we ask them to go to the nutritionist or the person who can give you the CQ10, and it's anyways an over-the-counter drug. It's just a macronutrient which you can take it. And if you take it, you will see that they don't really have to give them any needle cups or anything. So to go beyond the muscle, ligament, tendon, bursa, you can go beyond that and still get your results if you do it properly. So CQ10 is a nutrition of quadricep muscle. Every muscle has a particular nutrition to it. If you give them a right nutrient, the pain would be gone. Even though I correct the ligament, tendon, bursa, muscles, alignments, still it's not going. Look into the nutritional factor. You'll get your answers to it. Knee pain can be because of the emotions. Future worries, always worried about future. Kal kya hoga, kaise karenge, what to do, what not to do. Every time we think about a lot of future. That affects the thigh muscle, especially the quadricep, which can result in knee pain. Scramble thoughts, unnecessary thoughts which keep clicking your brain. These emotions usually affects the popliteus muscle, which can result in quadricep dysfunctioning and cause you pain. Ego, how can I not have this? How can I am that? When ego becomes pride beyond its limit, that is where you can have knee pain. So what we are trying to identify here, the knee pain is not limited to structures, tendon, ligament, bursa. Try to identify rather than working on the symptom. Try to identify where is the cause. So the whole idea of the musculoskeletal key of today's topic is to make you understand not to look for local structures. Look for global from pelvis to ankle. Look for nutrition like CQ10. Look for is your client more affected with the emotions and try to resolve them rather than just working locally around that muscle. That is going to maximize your healing response. For that, we have acknowledged the cause. For that, we already have batch 1 and batch 2 full. We are going with the third batch, which is on the July to December, in which we are trying to cover every 100 muscles, ligaments, nutrition, bursas, tendon, all the nerves which we have never covered and still covered in-depth assessment and treatment protocols for the same. And it is not limited to that. We are also trying to give you top 10. Whenever you do a needling session or a cupping session, maybe a manual therapy or anything that you like, and you're still not getting your results, we always tell our students to look for top 10. We call it as a top 10 chart. And if your answers has to be somewhere in this top 10 to give you maximum response. It can be a magnesium, it can be an emotion, it can be a hydration, it can be a nutrition. Any of these can also result in pain. So if you give these structures what they require to do it, the knee pain would be gone. Do not limit yourself to understand knee pain is limited to knee. If you think beyond that, the answers would be simple, easy, and structural. Constructive, less effort. And if you think that all the answers can be measured well, if a lot of client comes to us with knee pain, I just have to give them a hydration bottle. A lot of client comes to with knee pain, we just give them a right CQ10 by assessing it. And that knee pain has never came back. And the doctors diagnose them as meniscus injury or osteoarthritis and blah, blah, blah. We just need to resolve them. So the whole idea is for you to assess them properly. Try to identify them. This is not a platform where I can teach you the assessment of each one of these. This is a platform we are trying to explain you. Think beyond the limitations of local. You're not getting your answers, think of the global structures involved from pelvis, ankle, shoulder, elbow, TMJ, hyoid, sphenoid. If beyond that, magnesium, emotion, hydration, nutrition, we have 6 more to look into. We always get our answers into it. And is not limited to one. There are 10 and more plus lists into which we can look into it. And if you look properly, you will get most of your answers. They have to be there. So wherever you're missing these links, you're not getting your pain off. Don't say the client's going to take a long time or needs to work on. The pain can be reduced very well if you identify the structures involved and what affecting the pain. I just told you about one of the client about the frequency that I made her listen, and that has resolved the pain. So as I said, there is no standard answer to solving the pain. It is the in-depth assessment that you end up doing it that will teach you how to resolve that pain. Clear? So if you have a question, you can place it in the chat box and I'll try to answer that if I get it. How did you normalize the frequency? Please place it in the chat box if you have a question. Do not unmute yourself. We didn't normalize the frequency. We just gave them her right frequency to listen, and that itself resolved the pain. Can you show the basic assessment criteria? As I said, we don't have any criteria of basic assessment. If a client, we always do a static posture. We always ask the client to walk. If I don't see anything in static, I always look in dynamic. And in dynamic, as we teach you, it can be from glutes. I can see gluteal inhibition or abdominal weaknesses, or ankle is not having enough dorsiflexion, plantar flexion, or is it that tightening the jaw to move around? And we keep seeing them dynamically walking till we get our answers. So my assessment criteria are 2 simple assessment criteria. Criteria number 1, static posture assessment, and 2, dynamic assessment. Either one and we are done. Will this webinar be available online? I don't know, you have to ask the organizers. They would be able to tell you better. Any other questions anybody has?
Yes, sir. Sir, in the patellofemoral pain syndrome, the pain is around the knee. The main etiology is the affected knee, or sir somehow
It can be
globally, or sir?
it
No.
can be global. Usually it's not me. We usually see it either because of gluteus medius, or sometimes I see it because of just CQ10. Or maybe some other structures. Even the adductors can result in patellofemoral pain syndrome pain. So usually we never find it a local pain. It's always global.
Okay, sir.
How
Thank
to
you,
work
sir.
on emotional criteria of the patients? We always, emotional criteria, either you have to look around how to do it. People who have joined us in our FNMT 1 and 2, we teach them how to do an assessment. We have specialized bottles to place it on the patient's body, and if that reduces the pain immediately, which you can see on the right hand side top corner, just placing the bottles on the patient's body, if that reduces the pain, client is going through that emotions. And we have 25 stickers in which we have put up from relationship, ego, fear, toxins, uh, forgiveness. All these are the common emotions that we have tried to cover, which can result in pain. So that is how we go it. Or you can understand how to identify it is through, if you know any other emotional techniques, you can use them. There are many emotional criteria to do it, but once you know, you can talk to the client. I'm not getting the results. Can you talk about what are the factors that affects you the most? Are you worrying about the future? And as they start talking about it, they could see that the muscle intensity of the pain is reduced. So we want them to talk. If you know what are the emotions stored in those each muscles, maybe you can make them talk if you're not getting the results. COQ10 and CQ10 is same or different? They are same. If knee pain is due to global reasons, then will the main affected area always be symptomatic? Yes. Will be symptomatic or can be asymptomatic. Does not have to be symptomatic. Can you elaborate about CQ10? CQ10 is basically an anti-inflammatory drug. Nutrition in the body produces this to reduce inflammation in the body, and whenever the CQ10 is low, body has high inflammatory response, and since the knee is the most load bearing joint, the inflammatory response in the knee is most commonly high and wear and tear occurs, so that can result in knee pain. This is commonly seen in most of the clients, especially I have seen mainly with client with CQ10 would always just have a high response, and that can result in pain. So just giving you right medicine can solve you too. Any other questions? No questions. So if you like to learn about it in similar fashion in depth, I would like you to see it. I would like to see you in the FNMT classes. If not, this approach is to let you know, don't be limited, start thinking globally, and that should help you to look more wider aspects of life. Hope this seminar was useful to you to some extent, and maybe you get out of the local box. Clear? Thank you. I don't see any more new questions coming in.
Thank you, Dr. Saab. Thanks, everyone. And if you are interested in our courses, flyer is already shared in the group. You can go through that. Thanks, Dr. Jan. Thank you.